Bismillahirrahmanirrahim. Good morning and good afternoon. We welcome you all to our weekly virtual academic program. So we are trying to make a social connecting in the era of the social distancing. So this is the endeavor of that. And today our program, how should I treat my patient following evidence-based medicine? But today we have a different flavor. Normally the gentleman who become a guest faculty, he is a regular faculty. That is, our regular faculty is Dr. Farid Ahmed. We all know him. No need to introduce him anymore. But today he will be talking on a topic a bit interesting, that breast surgery, what oncologists need to know. So he will be trying to cover, I'm sure, some aspect that we, the oncologists, supposed to have some idea so that we can clap ourselves together and help the patient to go forward. And we are happy to have John back after a silent party. Even we missed the cake, but we said happy birthday to him. And I'm sure he had a good party with the family. And we are happy to have you back, John. We missed you last week. And along with John, we have Dr. Zakirullah, the person who has been supporting us from the very beginning. And already I talked about Farid, and we are always blessed to have our president and patron, Professor Ahmed, with us. So may I request Sir to formally start, and then we can go out to our session.
Okay, Bismillahirrahmanirrahim. Start immediately. Open the session.
Thank you, sir. So our meeting will be on for 90 minutes, and the distribution is like always: 15 minutes presentation, 15 minutes comments, and then question answer, case discussion, quiz, and stratification of the faculties are foreign and local. And we always encourage our postgraduate students to be the part of our discussion. That will, because they are our main focus. And we will be reviewing the last session, but let us first start with our today's presentation. Today, may I request Dr. Farid to make his presentation. Farid.
Thank you very much, Kamal, and assalamu alaikum everybody, and good afternoon, and in fact, good morning from UK. So, sure. Right. So, as Kamal has already said, we are going to discuss, in fact, share our knowledge, really. I don't dare to, teach our oncology colleagues. They already know more than me. The topics are going to talk about breast surgery and what is important aspects of breast surgery that the oncologist should know, and is vice versa. And to be honest, cancer management has moved a long way from the days of papyrus in 2500, 3000 BC. Those days, the breast cancer was deemed incurable. And 400 BC, Hippocrates, he actually termed cancer from the term carcinos, means crab. And the development carried on from 10th century, the rise of Islamic Empire, with various physicians, Ibn Sina, Abu Qais, and many others, has helped developing medicine, including surgery and everything. And in 1894, William Halsted described the surgery that became the standard of care for many years to come, the radical Halsted mastectomy. And from then on, things carried on moving, and a rapid expansion took place in 20th century. And in fact, 1967, Jensen described estrogen receptor that paved the pathway for developing estrogen modulating drugs. Following that, chemotherapy came into play with the US National Cancer Act 1971. There was a heavy financial input, and the rapid expansion of chemotherapy portfolio undertook. Things carried on developing, and this is the guy, Gianni Bonadonna, is one of the father of oncology. And the breast cancer chemotherapy schedules improved significantly from methotrexate combination to anthracycline, and incorporating to taxanes in 1990s. And it carried on. And this is the chap, Bernard Fisher, US. He actually changed the breast cancer surgery from horrendous hospital operation where the whole breast was removed, including the muscles and everything and the lymph nodes. And it gradually, the paradigm shift took place where sort of de-escalation took place, less and less. So less is more. That was the ethos. And gradually, this is happening up till now. And that time, it was first postulated that breast cancer is a systemic disease, just not taking the breast out will cure everything. Development carried on. Veronesi and Bonadonna in Milan aim to perform a partial breast surgery, like a breast conserving surgery, followed by adjuvant radiotherapy, chemotherapy, and tamoxifen, the hormone therapies. And the concept of sentinel biopsy developed afterwards. Personalized therapy came into play with various research and innovations, including molecular era of cancer treatment, where various subtypes of cancers, breast cancers like luminal A, B, HER2, and basal types were picked up. And the development carried on following introduction of breast screening program. Currently, 26 countries in the world is running breast cancer program, and 22 are doing 2-yearly mammographic surveillance. One is doing 3-yearly, which is UK, and one is doing 1 to 2 years flexible. And obviously, we know from the evidence that following the introduction of breast screening 1988 onwards, at the same time when the multidisciplinary team approach concept was introduced as well, we know that early detection saves lives. And through the multidisciplinary approach of managing breast cancers, we have got evidence to prove that the mortality was reduced 18% in 5 years. And these are the key developments that this too has helped in the breast cancer. Now, breast cancer cannot be just managed by one person. It is a team approach. And there are certain aspects of breast surgery which has developed significantly in the last 20, 25, 30 years, where oncologist colleagues do need to know a little bit more about that, so that the decision making comes more accurately and it does benefit patients. So this is just a summary slide. I wanted to say what I'm going to discuss. Based on cancer status, tumor biology, nodal status, performance status, patient's comorbidities, and obviously patient choice, and following an MDT outcome, we plan a treatment. And once that is agreed, whether it could be a neoadjuvant chemo or surgery for breast cancer, that MDT decision, we share this with our patients. And once it's agreed, it goes for neoadjuvant chemo, we refer this patient to our oncology colleagues to initiate treatment. And when it comes to surgery, the surgery has evolved like breast conserving surgery with various types of therapeutic mammoplastics, with a level 1 level 2 oncoplastic surgery, and central biopsies, axillary clearances, including post-neoadjuvant chemo, breast surgery, including axillary surgeries. The things we do need to know a little bit more details about this. And also, it's important to understand from the surgeon's perspective that orientation of the specimen, to put liver clips, marker clips at the tumor excision site, at the tumor bed, and specific mention about the tumor bed and the distance from the breast scar. Because of the therapeutic mammoplastics, we may put a scar somewhere where cancer could be, excess cancer could be somewhere else. So all these informations are quite vital. Now, when we see a patient, we take history and obviously examination, and we initiate some investigations. And the first breast cancer often can be detected through an abnormality on a mammogram, and that could be through breast screening if it exists. And the abnormalities that you could see is asymmetry, microcalcification, or a mass or an architectural distortion. And that's when you need to get an ultrasound scan, look at that area a bit more closely, look at the breast and axilla, and you want to do a biopsies as well. So mammographic along with breast ultrasound should be performed before a biopsy is obtained. This is quite a key information, and that should be the natural flow, not other way. Sometimes to evaluate the lesions a bit further and certain types of tumor biologies, we may want to get an MRI to exclude multifocality and contralaterality, for example, lobular cancer. And obviously, staging do play a role if you want to evaluate this further, if the cancer is spread elsewhere, and that would help with the treatment plan, including surgery as well as oncological treatment. Now, the points to remember is the post-core biopsy breast lump may feel enlarged. Overlying skin may look slightly erythematous and may mimic inflammatory cancer. So be mindful about that. And the post-core biopsy, you may even be able to feel a lymph node in axilla, which could be simply reactive. And simply palpable node doesn't mean that it has got cancer. And this may lead to a diagnosis of a locally advanced breast cancer inadvertently. And neoadjuvant chemo may be initiated, which may not be required at all for that particular patient in that particular tumor biology. So please do remember about that. Now, obviously, I've already mentioned about history examination and investigations is a good start. and mammograms and scans. And if ultrasound scan shows a lymph node, a cortical thickening of more than 4 millimeter, FNSC or a core biopsy with ultrasound guided of the lymph node should be done. And obviously, if it is a breast mass, we would urge that please avoid FNSC in order to get detailed histological information into the immunocytochemistry. With certainty, a core biopsy is the way forward for a breast lesion. And where we would like to know the tumor biology, nodal status, performance status, comorbidities, all this information that needs to be discussed in MDT and a treatment plan is agreed. And we must avoid an ultrasound guided FNSC diagnosed breast cancer. This is quite important that often we see a patient do not get a mammogram, we just get ultrasound and do an FNSC, and we start treatment even without any immunocytochemistry. And this is an absolute no. And I would urge you all to share this information so that we do things right the first time. Now, if you talk about neoadjuvant chemo, a surgeon will refer these patients to our oncology colleagues, and there are ways to select. I've given 4 options like locally advanced breast cancers, select cases of early stage of breast cancers, limited clinical node positive disease, or if there is a patient with temporary contraindication for surgery. And just to elaborate a little further, if it is a stage 3 disease, T3, T4, and not suitable for upfront surgery or resection, and obviously neoadjuvant chemo will help. And if it is an early stage breast cancer, if it is stage 1 or 2, breast cancer is not possible due to a high tumor to breast ratio. Suppose someone has got a A-cup breast with a 3 centimeter cancer, it will be difficult to do a breast conserving surgery with the appropriate cosmesis. But if that patient has got a 40 double G breast, obviously the 3 centimeter would be absolutely easy to do a breast conserving surgery. So it is individualized, case-based, based on breast to tumor volume, which is quite important. And then obviously, if it is HER2 3+ positive cancers, even early stage, or a triple negative cancer, or ER negative HER2 positive cancers, even if it is early stage, neoadjuvant chemo definitely will have a role. Now, we know that the chemotherapy prior surgery downstage the cancer as well as axillary node, and often a positive node could become a normal after neoadjuvant chemo. And for last point, I've mentioned that medical contraindications and other issues like patient is pregnancy. Sometimes you could give chemotherapy first, depending on certain time of pregnancy, and that is another topic to discuss in another day. And other patients may be requiring a long-term anticoagulation, maybe had a PE, deep vein thrombosis, or a placement of a drug-eluting coronary stent. So all this sort of situation, surgery can be delayed and neoadjuvant chemo could be initiated. Now, HER2 positive, HER2 negative tumor combination has got the highest rate of pathological complete response, followed by triple negative tumors. And there are several trials in the past have shown there is no survival advantage to neoadjuvant systemic therapy as compared to adjuvant systemic therapy. But there are some new changes that have taken place, and I'll come to some further down the slide. I will share the new changes. And the neoadjuvant systemic therapy allows the assessment of the tumor response to therapy, and complete response is associated with an improved survival. We know that. And there are other options like neoadjuvant endocrine therapy, also helps if it is a post-menopausal ER positive as an alternative, can be initiated as well. And the rates of eligible patients for breast conserving surgery are increased after neoadjuvant chemo, and that doesn't compromise oncological safety. So now this is the picture I wanted to show that here you could see cancer is there, and you could make incision right over that, and you could do a wide local excision, but you could also do a periareolar incision somewhere else around the areola, and you could subcutaneously dissect and reach around the cancer, and you could take it out. So if a patient needs a radiotherapy with a boost, looking at the scar, oncologists might be just giving radiotherapy boost right over there where the cancer tumor bed is somewhere else. So this is why I was trying to mention that it should be clearly documented by surgeons when referring to oncologists that if there is any therapeutic mammoplasty approach is undertaken, or if there is a surgery of breast conserving surgery is done where the incision is away from the cancer site, it needs to be clearly mentioned to benefit the oncologist to give the right area of boost. Now, what is breast conserving surgery? It is basically complete removal of the tumor with a concentric margin of surrounding healthy normal tissue. And to maintain an acceptable cosmesis is quite important to understand. The cosmesis is quite key, and this should be followed by radiation therapy, and there has to be an acceptable low rate of local recurrence. Now, the points to remember, as I've already mentioned, the surgical excision site may not be at the underside of incision, which is quite important to understand, and boost radiotherapy must be at the tumor bed, not at the site of incision. And placing surgical clips at tumor bed during surgery by surgeons is absolutely beneficial for the oncologist to determine the area to be boosted. Now, surgery-wise, it has developed so many different options. As you can see, a wide local excision or a wire-guided wide local excision, if it is an impalpable lesion, either patient presents through screening or after neoadjuvant chemo with a complete response, then obviously following the marker clip, you could do a wire-guided wide local excision. And obviously therapeutic mammoplastics with various techniques have come into play, and that has developed breast surgery with aesthetics significantly. And obviously mastectomy, there are various types: a simple mastectomy, skin sparing, or a nipple skin sparing mastectomy. So all these things, with or without reconstructions, have come into play. So breast conserving surgeries as well as mastectomies has got different options. We need to be flexible about knowing the possibilities. And when it comes to axillary staging, axillary sentinel biopsy, OSNA, if it is available, which is one-step nucleic acid amplification, and obviously if it is a positive node, axillary clearance still been practiced routinely. Now, I just share a little bit about what are the breast conserving surgery steps. Like 80-90% of breast conserving surgeries you'd be able to get with a level 1 oncoplastic surgery, where you excise from your skin to pectoral muscle, as you can see on the picture, and extensive undermining usually is taken place, and cavity sort of immediate reshaping is taken place to close the cavity. Sometimes nuclear complex is undermined and recentralized. And if cancer is found to be positive on histology at the anterior or at the deep, either anterior or at the deep, and we have excised skin to muscle, there is absolutely no need to go back. So this is quite important for our oncology colleagues to understand. If it is documented clearly in the operation note by surgeons that they have excised the cancer from skin down to chest wall muscle, and if the histology shows the cancer is positive at the deep, which is to the muscle, or positive entered to the skin, there is no point going back. Simple adjuvant radiotherapy and other treatment should be sufficient. So this is quite an important information to understand, to remember. Now, breast conserving surgery followed by radiotherapy, it's kind of like equals to mastectomy, and randomized control trial showed no survival benefit. This is a very well distributed sort of scenes in many presentations of that was New England Journal of Medicine that came out in 2002. They showed with a huge number of patients with some 20 years of follow-up, showing there is actually no benefit. In fact, subsequent publications showed other way, that if you do breast conserving surgery radiotherapy, it has got a better outcome than mastectomy. And you see, it's not only equal, it's in fact better. So these sort of things, as a surgeon as well as oncologists, we should keep it in our mind that de-escalation is key, and there is no compromise of oncological safety if you do breast conserving surgery. Now, I've just shown some photographs. May I request those who are listening, just put on mute. There is a lot of background noise I can hear. Apologies. I'll continue. So this is some pictures for ultrasound-guided wire localization for impalpable cancer. As you can see, the sonologist is pointing out on the local aesthetics, the wire is inserted, and this is the lesion, as you can see, and the wire is inserted, and then it makes our life easier. I can still hear a lot of background noise. May I request
everybody
please mute?
John, make everybody mute, please.
সকল participant বলা হচ্ছে
So these are post-excision wide local excision, where you could see the wire-guided wide local excision specimen, and you could see those clips that we often use it for clipping during laparoscopic surgeries. And these are the clipper that can be used on the specimen to extray the specimen, but at the same time, this can be used for putting the clips in the tumor bed. That helps our radiation oncologists to locate the area of tumor site for boost radiotherapy if needed. And this is how you X-ray the specimen in Bangladesh and UK. These are the mobile cabinets. We X-ray the specimen, and that's how the marker clip is done, shown there, and the wire is inserted, and that's how the wire-guided wide localization is done. Now coming to Xray staging with central biopsy, we inject isotopes and dyes, and you could see a blue node, and obviously that's how it is. It's taken out with minimal damage and dissection to axilla, but we try to obtain maximum information. Now, when it comes to neoadjuvant chemotherapy, it's absolutely mandatory that in order to get the true benefit of chemotherapy-related downstaging, enabling to perform a breast-conserving surgery, what if there is a complete pathological response? Then you would have no option but to do a mastectomy. And this is when these sort of techniques we have introduced through technology transfer in Bangladesh. These are now readily available in Bangladesh, where under local anesthetics, a palpable large cancer who is selected for neoadjuvant chemo, before you start neoadjuvant chemo, you insert that marker, hydrogel marker clip, into the center of the breast cancer, and then obviously it will be done under ultrasound guidance. And this is how it looks like. It's a magnified view, and there's the hydrogel with a little bit of marker at the center. And this is the picture how it looks like. So this helps the sonologist to detect the area of residual cancer burden post-neoadjuvant chemo. Even after a complete response, you could do a wire-guided wide local excision without having to remove the whole breast. And that's how it looks like, a hydromark on ultrasound, as you can see. Now, neoadjuvant chemo with a marker clip, as I've said, just to summarize, it needs to be placed at the center of the tumor, and it risks unnecessary mastectomy if you don't put that. If there is a complete response, and insertion of a marker clip is mandatory for a single breast cancer with a view to downstaging for breast conserving surgery. Now, when it comes to axilla, if it is positive preoperatively through ultrasound, FNSC or a core showing a positive metastatic lymph node, and once appropriate treatment is done or surgery up front or neoadjuvant chemo, patient should have a level 2 axillary clearance, and that is actually the current practice at the moment, which might change. I'll explain why. And when you do axillary clearance, it is absolutely important that more than 90% of cases, at least 10 nodes should be present on axillary clearance in order to get the true representative sample from axilla. Level 3 axillary clearance kind of gone obsolete, and as you know, we are doing axillary surgery for staging to get the prognostic information and to give treatment planning. These are the information. There is no survival benefit for axillary clearance. Now, axillary central biopsy needs to be done. If it is clinically negative axilla, then obviously SNB and OSNA, if it is available, or simple SNB with frozen section can be done if patient is neoadjuvant chemo patients, because if frozen section of the lymph node showed even few cancer cells or micromets, we should still be doing axillary clearance, but that again is changing. Now, these changes have all taken place based on Z11 trial as well as subsequently Amorous trial, and combination of both these two, we have moved a long way from this sort of mutilating surgeries. Now, there are several meta-analysis systemic review published evaluating the identification of rates and false negative rates of SNB after neoadjuvant chemo. And in fact, it's ranging about false negative SNB is about 9%, and 90% or more, you should be able to get the right information, and it's quite statistically significant, and we should be continuing to do this practice. This is what I was talking about, the future. In fact, it's been happening in many units in the UK, a targeted axillary dissection or TAD. And patients undergo a central biopsy together with excision of the biopsy-proven lymph node at the diagnosis. How do you do that? If before neoadjuvant chemo, if the node is positive, you put a marker clip, either it's a radioactive clip or seed at the node. So you clip the node, and patient gets neoadjuvant chemo, and afterwards you do at least a 3 node SNBs where you take the clip node out, and if that is negative, often so no further surgery is done. Now, one of the important dilemma comes in management of breast cancer post-neoadjuvant chemo. Should we do a breast conserving surgery or a mastectomy? And in fact, one of the reasons for doing neoadjuvant chemo is to downstage and enabling to do a breast conserving surgery. And the clinical response rate of primary tumor to neoadjuvant chemo could be up to 80-90%, depending on the biological subtype of the disease. And there has never been a randomized trial compared to outcome of breast conserving surgery versus mastectomy for patients with large breast tumors who achieves a favorable response to neoadjuvant chemo. And neoadjuvant chemo is now considered to be a standard for patients who desire a breast conserving surgery. Now, the volume of surgical resection should be smaller and directed at the residual nidus than the original extent of the disease. Is absolutely important not to excise the whole tumor size pre-neoadjuvant chemo. We will be guided by what is left after neoadjuvant chemo. But there is an exception. Sometimes post-neoadjuvant chemo cancers can have a diffuse pattern of residual multifocal microscopic disease and calcification. And be mindful, after neoadjuvant chemo, get an MRI. Even if clinically you do not feel the lesions, and if MRI shows these sort of changes, avoid a breast conserving surgery. But these are chances are usually pretty slim. Now, post breast conserving surgery, poor patient who has had adjuvant radiotherapy presents with recurrence, what we're going to do? We should always stage the patient, CT chest, abdomen, pelvis, and a bone scan. If staging is clear, you should do mastectomy. If it is a small, even if it is a small recurrence, but if original surgery, breast conserving was done with no radiotherapy given as an adjuvant setting, and patient has got a cancer recurrence, after staging, if it is clear, then you could do breast conserving surgery. It's perfectly safe, and it doesn't compromise oncological safety. Now, there are a few slides. I apologize because it's quite a busy slide. I'm showing NSABP B18 and URTC 10902 trial showing the rates of breast conservation, the local regional recurrence, survival, and randomized prospective clinical trials comparing neoadjuvant and adjuvant treatments. They are showing kind of like no difference, but as you can see, they are showing no difference when the recent publication from a large meta-analysis came out in online publication was done on February 2020. I'm thankful and grateful for Kamal Bhai to supplying me this because he presented this in our last international breast live surgery workshop in Dhaka. He did present that and he shared this slide. So thank you very much for him. These new data suggest there is actually, contrary to the previous belief, the complete pathological response after neoadjuvant chemo and the impact on breast cancer recurrence and survival on the meta-analysis does show that there is a benefit on overall survival if there is a pathological complete response, as well as event-free survival. So pathological complete response, if it is observed after neoadjuvant chemo, they show significantly better event-free survival as well as overall survival. So things are changing, and you see the information always changes based on the evidence, and this is the evidence. And this is the conclusion from the meta-analysis, the huge number of patients confirming the benefit of neoadjuvant chemo if patient has got complete response, and then patient would have a better event-free survival and overall survival. Now, how much tissue to be resected post-neoadjuvant chemo? Buji et al. Suggested same thing as I was mentioning, that you do not need to excise the pre-neoadjuvant chemo tumor size. In fact, what is post-neoadjuvant chemo, what is left, and surrounding 1 centimeter additional tissue should be more than enough. In fact, you just need 1 millimeter clear margin to be able to say surgically complete excision margin. So it's not necessary to excise the entire pre-chemotherapy volume of cancerous tissues. Now, I will just give in one slide for DCIS. If there is a large area, then obviously you should be doing mastectomy and reconstructions. But if it's a smaller area of DCIS, come from on core biopsy, triple assessment, you could easily do a wide local excision through a wire. And if breast conserving surgery is done and histology shows a high-grade DCIS or a large area of intermediate grade DCIS, radiotherapy should be offered. And radiotherapy can be avoided if it is a low-grade DCIS or a small intermediate grade DCIS. So these informations are quite helpful. And obviously, we all know that there is no need of chemotherapy for DCIS. It is not that it has happened in some parts of the world that patients with DCIS has been treated with chemotherapy. So I'm sure our colleagues are very well aware of this, that there is absolutely no benefit with that. Now, For Xray staging for DCIS, there is no need if you're doing a breast conserving surgery unless there is a mass lesion shown on images and repeated core biopsies show DCIS. Then you could still, if you suspect if there is a suspicion or high suspicion of invasion, and then you could do Xray staging. Otherwise, simply just do wire-guided viral excision. And if you do mastectomy, obviously, for DCIS, obviously you should be staging SMB in case there is a hidden focus of invasion. And one thing to remember that hormone therapy should be considered if ER is positive, because NICE guidelines were almost 8-9 years were suggesting that to avoid hormone therapy for DCIs, but it's about 2 years now. Things have changed based on evidence. Now there are certain myths exist. I understand there is a time constraint. I would be speeding it up as much as possible to finish it up. Sorry for taking extra time. There are lots of myths exist which must be contested, like mastectomy is superior to breast conserving surgery for survival. In fact, it's other way true. Node positive axilla with breast cancer equals to mastectomy and needs to be mastectomy and clearance. Mastectomy is not determined by the nodal status. It will be determined by the breast tumor size. So that is definitely a myth and must be contested. Post breast conserving surgery with clear margins and a sentinel biopsy, which is normal, it is recommended by some of our oncology colleagues in the past that patient needs to have a completion mastectomy. Please don't. Absolutely no need. Often it is thought FNSE is enough to proceed to breast conserving surgery. Please don't. No mammogram required prior surgery if ultrasound and FNSE shows cancer cells. Please don't. Mammogram is absolutely mandatory to have a baseline information looking at the remaining part of the breast as well as contralateral breast. Now, another myth is surgery is always the first line of choice for breast cancer. No, oncologists play a big role in managing cancer, and neoadjuvant chemo have a significant role, as I have already alluded. Level 3 breast cancer improves survival? No. In fact, axillary clearance do not have got any implication with survival. Surgeons or oncologists solve everything. Again, it's a total myth. We can't. We have to work together as a multidisciplinary team approach. Now, I'm almost coming to an end. Breast cancer surgery is more than just surgery, and it offers a holistic approach to patient care with a strong ethos of team working. And the optimal management of patients with breast cancer requires expertise of specialists from various different disciplines. And the key professionals join together to discuss individual patients to contribute independently to an agreed clinical decision associated with an 18% lower cancer mortality at 5 years. This is evidence-based. Therefore, gold standard is MDT. So this is absolutely important that a surgeon, oncologist, pathologist, radiologist combinations, all together has play a big role making patients' life better. So my last slide, just to say thank you, that cancer care is a high emotion service, which is characterized by a lack of customer control, feeling of powerlessness, severe consequences if things go wrong, high complexity and long duration. The wonders of high-tech cancer care are best complemented by humanity of high-touch care. And this message I would like to put both for our surgical colleagues, for myself and for our surgeons, as well as my oncology colleagues. Thank you very much for listening.
Thank you, Farid. I didn't know that you will be telling so many things. I was asking for something, but you have done so many things. You really, I'm grateful to you for so many informations. Now the floor is open for question, but I see there are some question in the chat box. Windows 10, I don't know who he or she is. Will you please unmute yourself and ask the question you wanted to know about OSNA and wild localization. Windows 10.
Should I answer or
yeah, please.
Hello?
Hello, this is Dr. Aisha from Pakistan, and I have put these questions. Yes, the OSNA is new term for me. I want to know about it. And secondly, I always feel difficulty in marking the margins when we are sending the specimen for specimen radiograph, and then the radiograph comes back, then we just get confused which margin represents which margin. So, and I've seen a lot of differences in the practice of marking these margins. So I want to know about the experience of Dr. Farid in this regard? Thank you.
Aisha, thank you very much for joining. One thing is OSNA, one-step nucleic acid amplification. It's not quite a new concept. Maybe it's a new concept in certain parts of the world, but in UK and other developed countries, it's almost 15 to 17 years it's been ongoing. And that's the SNB, and OSNA, we are doing it over 10 years. What happens is the lymph node do not contain CK19 mRNA. These are present in the breast duct epithelium, and if the cancer cells develop within the breast duct epithelium, and if they metastasize from the breast to lymph nodes, they will carry those CK19 mRNA copies to the lymph node. Now, these are the molecular biology technique. Once you've done a sentinel biopsy, the node is sent straight out to lab, and the lab will mesh the whole lymph node lysis and the cells. Then they will identify the number of copies of CK19 mRNA, which are normally absent in the lymph nodes. And in the metastatic setting, there will be positive CK19 mRNA, and if the number of copies are more than 5,000, we call it macrometastasis. If it is less than that, we call it micrometastasis, and if it is below 250, then we call it negative. And the initial days of OSNA, we used to do Xray clearance straight away if our pathology reports within half an hour that the patient has got macro or micrometastasis. But later on, we found out there is no benefit, and based on various trial evidence, so OSNA is mostly now limited to neoadjuvant chemo patients. If the neoadjuvant chemo SNB OSNA is positive, we then proceed still to do Xray clearance, but this might even change in future. Now, your second query is regarding orientation of the specimen after you've done a breast conserving surgery. As you can see, can you see this X-ray where there are clips? You could put clips there on this presentation. You will have those slides shared later on. AIM, AI aim. A is anterior, I is inferior, M is medial. So you could put anterior 1 clips, inferior 2 clips, titanium clips, and medially 3 clips. So you get a 3-dimensional orientation. You've done an X-ray, and you'd be able to see the cancerous part in the middle of the excised specimen and how far distance from the marker clips. And if any margin is closed, you could straight away do a further re-excision of margin at the same anesthesia once you get the films available during surgery, perioperatively. And when it comes to pathologists to send the specimen, try to do a common orientations tricks. As you can see, there are sutures there. You see, superior for short, SS, LL, lateral long, DD, double D. And that's how you orient the specimens. And with radiological marking, you do it through the metal clips, and specimen orient for the orientation for pathologists, you should be putting sutures as well. By doing this dual technique, and you send the specimen, you should be able to get a proper histological assessment of margins. Does it answer your query, Asha?
Yes, thank you, Dr. Farid. It actually does. I just want to ask, are the same clips the Liga clips that we use for marking?
You can do that. That's why I'm saying that you have to be innovative. You could do those Liga clips. Basically, they're titanium clips. And the one that you do for gallbladder surgery, same thing, you could very smaller clips on the tumor bed so that it helps the radiation oncologist to locate the tumor bed for boost radiotherapy. You could use the same clips on the excised specimen to get a 3-dimensional radiological view. And as you can see there, Aisha, can you see there is one marker clip that's called anterior? So that is anterior.
Yes,
and
yes.
There are 3 clips like inferior. So there's anterior 1, inferior 2, medial 3. That's how we differentiate. That's how it looks like on X-ray.
Okay, yes. Thank you.
Thanks for the question.
Kollol, there is a question from you. Will you please unmute yourself and ask the question? Kollol.
Okay, thank you, Farid bhai. It was a nice presentation. You summarized the whole history and the surgical scenarios, as well as the chemotherapy, hormone therapy, immunotherapy, everything. It was a nice presentation. Thank you very much. My question actually was regarding the footprint issue. So you said that after neoadjuvant chemo, we need not to excise the original footprint, right?
That's correct.
Yeah. Okay. So this thing is very much important because many a times we found that after surgery, after removing the original or removing the remnant or the residual tissue after the neoadjuvant chemo, sometimes the oncologist, when the patients go to the oncologist, they sometimes refer back to us that the surgery was not appropriate or the surgery was not finished yet, so you need a further surgery. So I just try to emphasize that as our oncology colleagues are here, so this is a very important point, and sometimes it makes the surgeons very embarrassed in front of the patient. So we all should remember this thing. Thank you very much.
Thank you very much for your comments. Very valid point. One of the ethos for neoadjuvant chemo is to downstage that enables you to do breast conserving surgery. And there are so many publications, so many trials confirming same thing again and again. So based on all, this is evidence-based medicine, and it is absolutely oncologically safe not to excise. For example, somebody has got a 5-centimeter cancer, and it's a grade 3 or a triple negative. You done a neoadjuvant chemo, and it totally disappears. All you do is a wire-guided white excision. Now, does it mean that you excise 7-8 centimeter of tissues? Absolutely no need. Or I twist the example in a different direction. If there is, say, 5-millimeter lesion is picked up, 5-centimeter cancer is shrunk to 5-millimeter. So there is no need to excise 5-centimeter or surrounding tissues. You just take extra centimeter beyond that 5-millimeter lesion that was picked up on post neoadjuvant chemo images, and that should be sufficient. And to be honest, I know there are facilities of frozen sections in certain parts of the world where they could just tell you there is a margins are free or not. You could, with one anesthesia, you could do re-excision of margins if pathologist says one margin is positive, and that's why the orientation of the specimen is quite key. In UK, in the current practice, we are actually taking this patient back. If the margin is positive, which is about 15 to 20% cases, we are taking patient back in a different date to do margin surgery for any such a breast conserving surgery, be it neoadjuvant chemo status or without. But you have raised a very valid point, and I'm sure our oncology colleagues will be mindful about that. And I'm sure they are now fully aware of this potential change, that there is absolutely no need to take the original tumor size. Instead, you'd be guided by what is left post neoadjuvant chemo. Thank you.
Farid, another question regarding this issue. Another question is, you mentioned that we should sometimes we need to do MRI after neoadjuvant chemo because sometimes the regression of the tumor is not concentric, rather it is like focal. So there are multiple focus as well. So in which situation we think that we should do MRI after neoadjuvant chemo before going for a breast conserving surgery? Is there any rule or any guidelines?
No, thank you. Well, I can tell you what's happening in UK. We always would do an MRI. If you decide for a neoadjuvant chemo, we would request any staging CT chest pelvis and an MRI of the breast to look at the pre-neoadjuvant chemo status of that lesion compared to the remaining breast tissues and the contralateral breast. And based on that MRI finding as a baseline, post neoadjuvant chemo, we do another MRI and we compare it. And if the MRI pre-NSC shows scattered lesion or not like a well-defined mass lesion, and there are classifications in picked up on MRI or mammogram as well, then you would be mindful that they may even if there is a regression, there may not have a complete sort of downstaging. So again, breast conserving surgery is done, and if you have got the facilities of frozen section, you might be able to know straight away with one anesthesia. So that's one option. But as I said, if you haven't got the facilities to do an MRI, at least do an ultrasound scan, pre-NSC and post-NSC. So don't just rely on purely on clinical examination. But I think Bangladesh, many places MRI is readily available everywhere, and if facility permits, I would recommend you should do an MRI pre and post neoadjuvant chemo.
So
Thank you.
we do the ultrasound pre and post neoadjuvant chemo. But is there any specific indication for doing MRI? That was my question.
Well, I've answered it. Developed countries, we routinely do MRI for every patient, those who gets neoadjuvant chemo.
Okay.
with few exceptions. In Bangladesh, many places we've been practicing neoadjuvant chemo followed by breast conserving surgeries with marker clips. I've been practicing it almost 2.5 years, and many of my colleagues in Bangladesh, in Dhaka, they're practicing it, and MRI is done. So it's nothing like you cannot differentiate which patient you should be happy just with an ultrasound, which one you should be doing an MRI, based on the facilities and patient's ability and the technological facilities availability. You should, the recommendation, you should be getting an MRI, because MRI is obviously superior to an ultrasound scan to delineate the changes accurately, more accurately as far as image is concerned.
Thank you.
Thanks.
So Riyadh, I think you have a question there. Would you please unmute yourself?
Yes, sir. Thank you, sir. Sir, my question is, the recommendation is if clinically if clinically palpable nodes, we should do FNAC or core biopsy, and if it is positive, then we go for axillary dissection. So my question is, if there is FNAC or core biopsy positive axillary lymph node before neoadjuvant chemotherapy and it completely disappear after neoadjuvant chemotherapy, then is there any role of sentinel lymph node biopsy?
Yes, there is. There is. Then remember I showed one slide, TAD, targeted axillary dissection. You put a marker clip. You put a marker clip. There it is. You could see the clip is placed on the lymph node. All right.
Yes, sir.
And then the chemo starts, and that positive lymph node, which has already got an in situ, a clip. What you do during targeted axillary dissection after neoadjuvant chemo, you do SNB, and you take that targeted node out, and as well as another 2 or 3 nodes out, at least 3 nodes to be taken out. And then if that is negative, if the targeted node is negative, some centers are stopping doing axillary clearance. So things will change. And in fact, I can tell you, I haven't included on that slide, in USA, there are several centers are running even breast surgery, post-neoadjuvant chemo. If there is a complete response, after neoadjuvant chemo completion, they do further biopsy. And if the biopsy shows no cancer left, they just follow them up with 6 monthly. The trial is ongoing in MD St. Anderson, Mayo Clinic, and quite a few other larger breast centers are running this trial. And there is a small possibility that once a further larger trial is done, and maybe in 5 to 10 years' time, you might be avoiding even breast surgery. Forget about axillary surgery. You might be even avoiding breast surgery post-neoadjuvant chemo, even a large cancer, if it is shrunk with a complete response, evidenced by post-neoadjuvant chemo core biopsy, then you may not even need to do surgery. So things are changing. You see, de-escalation is the key. Or in other words, as you can see, less is more. So we are doing less and less as time goes by based on evidence. So as I said, neoadjuvant chemo, there is a role of SNB. But if neoadjuvant chemo patients had pre-neoadjuvant chemo normal axilla, after neoadjuvant chemo, you should still be doing SNB. But your question was, if the node was positive and you've done SNB and there is a complete response of breast and axilla, current practices, you are doing axillary clearance. Okay?
Thank you.
Maybe if you got the facility of TAD, then you can do targeted axillary dissection and you can avoid axillary clearance. But maybe this is the future.
Thank you, sir.
Thank you,
Thank
Riyadh.
you very much.
Dr. Mannan, I think there is a question. Dr. Mannan. A.B. Mannan.
Yes, sir. Thank you, sir.
Please.
Thank you, Farid, sir, for your wonderful presentation. Actually, quite a lot of few new things had learned by you, sir. So my question is regarding the surgery, though, what will be the resection margin in case of in situ and in case of invasive disease? Is there any difference of resection marginal status, clear resection marginal status?
Well, the guidelines keeps changing. For last several years, there is a steady guidelines, which is for DCIS or invasive. If histologically, pathological specimen, Xray specimen shows 1 millimeter clear margin, surgical treatment is complete for breast cancer. Clinically, when you're operating perioperatively, if you feel a lump, if you could take at least a centimeter extra normal tissues, you should be okay. And if you are able to do without compromising aesthetics, always remember, without compromising aesthetics, if you're able to take a bit more tissues, and then obviously with level 1 or level 2 oncoplastic surgeries, you could maintain the aesthetics. You can exercise a bit more for your safety. What do you think, Zakir Bhai?
I completely agree, Farid. Absolutely. I mean, it doesn't matter whether this is DCIS or invasive cancer. In the United Kingdom and all other countries, we normally keep 1 millimeter margin. This is absolutely safe. In America, they do cells on the ink surface, but I think that's a bit difficult to do. And you cannot be absolutely sure about that. That's why 1 millimeter margin is absolutely fine. I know that in Bangladesh, sometimes somebody was telling me that DCIS 2 millimeter and invasive cancer 1 millimeter. No need to go for that. Just keep remembering one thing, 1 millimeter for both these kind of cancers. I agree with Farid.
Thank you. Anand, you got your answer? Thank you.
Shahid Alam. Lima. Unmute yourself, please.
Fantastic presentation, Farid Bhai, as usual. So my question is, so we know the sentinel lymph node biopsy is the standard of care for clinical N0 but the reality is that it's not widely practiced in our country. So there is a paper from Tata Memorial Hospital that showed that axillary sampling, that means removal of 3 to 4 nodes just below the second intercostal brachial, is as good as sentinel lymph node biopsy when you don't have the blue dye or radioactive tracer. So I just want to hear a comment regarding this from you.
Thank you, Shaira.
Can you practice this?
Did you read that paper? Did you read that paper completely?
Not the whole.
Tata,
yeah.
You reminded me a story, but I don't want to share this story today. I'll just answer that. In fact, on that paper, when they are doing SNB, they're using dual tracker technique, isotope and blue dye, which is the standard. But the biggest mistake they did, they took highest node SNB was 14 or 18 lymph nodes, and the lowest was 1 lymph node. Average was 7.8 lymph nodes they took out. And they compared with low axillary dissection, And then comparing these two, then they recommended that SNB, we can avoid SNB, just do low axillary dissection. In fact, this paper can be seriously contested because when I was in a teaching session in a different place, I'm not going to mention exactly where, the presenter was telling me that Tata has redefined the definition of SNB. And I said, how? And they answered me that they picked up the lymph nodes that were hot, means isotope signal was there. No matter even normally, if it is less than 10% hot from the high signal, we don't do any more excision. But they didn't follow that. They said any hot nodes, they took it out, number one. Then any blue node, they took it out. And then anything that is palpable, they took it out. Adding it all together, they said essential biopsy. Then I said, in fact, that is not SNB. Anywhere in the world, they would not accept is a definition of SNB, what Tatas have done on the paper. And that is called axillary clearance. If you've done a 17, 18 nodes, in fact, if you have at least 10 nodes in axillary sample, that is called axillary clearance. So I would be very much cautious about citing that single unit paper when they have modified the worldwide accepted definition of SNB. So I wouldn't make any more comments, and I would say that's not recommended. One thing I can tell you, if you haven't got blue dye facilities, which cost only 200-300 taka, if you haven't got the technology or training available, then at least you could do simple level 1 or level 2 axillary clearance. But as I said, things have moved on, and every effort should be given to undertake the newer techniques, and which is oncologically safe. But thank you very much for your question.
Zakir Bhai, would you like to make some comment? It is a sensitive issue. I want to hear from you. Zakir Bhai.
It's a quite interesting thing. I mean, I've heard from Farid about this thing, that definition of sentinel lymph node biopsy has been changed by somebody in Tata and Bangladesh. I think you need to go through a training process. Shahida, what the question you asked, that was actually thought about that process in 1989 by the Edinburgh group, when there was no facilities for sentinel lymph node or anything, and even the concept wasn't there. So they started 4 node sampling, and that was in 1989 and 90. And that continued until 1996, 1997, when this technique of sentinel lymph node biopsy, Giuliani in America first started in 1992. Then in England, it came probably about 96, 97. And we had to all go through a training process to learn how to do sentinel lymph node biopsy. This is not a thing that you just do, as somebody's telling you, this is the way to do it. No, you have to go through a training process. I completely understand the concept in Bangladesh or even Tata Memorial India. Probably they haven't got the training how to do the sentinel lymph node biopsy, but that should not be the way to change the definition of sentinel lymph node biopsy. Taking 8 or 10 lymph nodes, it's not sentinel lymph node biopsy. Now, can I ask you, I mean, do you know how many lymph nodes you need to take to do sentinel lymph node biopsy? If I tell you, probably you'll be surprised, it's actually a single lymph node. You don't have to take more than that. However, sometimes we have got some branching process, that's why you take 2 or 3. But on average, internationally, it should not be more than 2.2 lymph nodes.
Yes,
so
that's correct.
Please remember, don't change the definition. Please try to understand what is the concept of sentinel lymph node. This is the most closest lymph node, close to the axilla. It means very low lymph nodes. Sentinel lymph node is never at the highest level. Never. I've never seen. It is the lowest one, mostly at the crease of the last hair follicle of the axilla. That's the area where you normally need to make a decision. So please remember, sentinel lymph node is the way forward. Okay.
Shahida, can't hear you.
But that study, they removed 3 to 4 lymph nodes below the second intercostal brachial, not the 8 to 10 nodes. So I think this is for our this type of setting. So you don't recommend without absence of blue dye, we can go for this type of sampling technique.
Look, Shahida, this was discussed in ASUMAL, Asian Society of Mastology. The professor of Tata did present that. Prior to that, in Dhaka, one of those oncology school, one of the trainees, they were presenting this, and we had a very elaborate discussion about the whole paper. So I don't want to go through this because it could be another 1 hour discussion. What Zakir Bhai said is the basic. If you haven't got the technology, you could still do either do a sampling or a level 1 clearance. Obviously, avoid a level 3 Xray clearance. But I don't want to compromise the proven benefit of SNB. I do not want to change the definition of SNB worldwide accepted based on one Indian institute. It has to be internationally agreed with a large multi-center trial. Then you could change the definition and practice. Thank you.
Thank you, Farid. I think Tata is a wonderful center, but it is not, I mean, whoever he or she may be, we need to follow the international protocol and the guideline. What Zakir Bhai said, teaching is teaching, guideline is guideline. I can respect you, but I am not supposed to accept everything. So I think Dr. Debraj has a comment and a question, but in the meantime, there was a comment from Dr. Nafisa. I am adding that within 300 taka, fluorescent dye can be used if we don't have the costly blue dye. I mean, that was her comment. So Debraj, would you mind to ask the question?
Thank you, sir. A very nice presentation. I have a rather silly question, I think. If the tumor is centrally located, in case of breast conserving surgery, is there any chance of disruption of the lactiferous system, or do you face it?
Thank you, Debraj. If there is a subarachnoid lesion, confirmed on triple assessment as a cancer, and you could still go through same technique if you're given chemo or if not. But if you talk about surgery, you could safely do a breast conserving surgery. We call it wide central excision. You excise the nipple and areola, underlying cancer, and exactly same principle of breast conserving surgery. You know, older textbook will tell you a subarachnoid cancer is a mastectomy, but that has got changed almost 15, 18 years. In UK, we've been practicing almost 18 years plus. I remember that we stopped doing mastectomy for centrally placed cancers. We still get away with the same principles for breast conserving surgery. And obviously, if you excise that, the lactiferous ducts and everything is got to come out. Patient won't be able to breastfeed anymore. Is that what you're asking, Debraj?
Thank you. That was what I was asking. Thank you, sir.
Thank you.
So I can see that even the lecture was on surgery. We had a wonderful participation, 72 participation was there. And I shall appreciate if there are any more questions from the juniors, especially. Any more question?
Kamal sir, can I add one
I
thing?
have one question.
Yeah, please. Somebody, Kollol, can you just allow somebody, then you come later on.
Sure, sure, sure.
Voice.
Who
I
is
have
this?
one more question. This is
Yes,
for
Aisha.
Aisha, the same. Sir, I want to ask that when the tumor is located very close to the muscle, pectoralis muscle, and we put the clip in it before the neoadjuvant chemotherapy, give the neoadjuvant chemotherapy, the tumor shows significant response and regress completely. Then sometimes even the clips placed in the tumor because of the location too close to the muscle becomes so unidentifiable and unlocalizable that we often find difficulty in localizing and excising such kind of the lesion. What is your practice in doing the wide local excision for such kind of the lesions which are so closely placed too close to the muscles and regress completely after neoadjuvant chemotherapy? Thank you.
Thank you, Aisha. Good question. In fact, the principle of breast conserving surgery would apply for any sorts of scenarios, location of the cancer, be it attached to the very close to skin or very close to chest wall. You would still go through the principles of breast conserving surgeries where you excise from skin down to muscle. And obviously, you could leave more tissues anteriorly and excise more widely at the deeper aspects because the cancer is placed at the muscle. Now, the problem that you have described is a radiological issue. If the marker clip or we call it hydrogel or different types of clips are available, is inserted prior neoadjuvant chemo appropriately at the center of the cancer, even if it is close to the chest wall muscle, it should still not move. And once the cancer is shrinking, the marker clip will still be visible. But if it is a very large breast, I understand this is a challenge. Our radiologists do face the same problem. Then you could just doesn't have to be ultrasound. You could sometimes be taking help from a mammographic, that is called stereotactic localizations. So there are various options available to locate it with great difficulties, but our radiologists do manage to identify those deeply placed lesions. So it is all down to expertise of the radiologist, and it is possible. Thank you.
So, Dr. Kollol, your question, please.
Yeah.
In the meantime, I request that whoever is participating, please put your email number so that later on, sometimes we cannot identify you, we cannot communicate further. And there is a link for the bonus point. So who wants to claim your bonus for the award by participating in the question answer, please register there in the link. So Kollol, now it's you.
Farid bhai, the question is, if I put a clip in the center of the tumor and then go for neoadjuvant chemo, and then after the neoadjuvant chemo is complete, I see that the tumor is, the clip is somewhere else, and the shrunk tumor is somewhere else. So what will be the next step for that?
How often have you seen this?
So very rare. It's a very rare scenario, but
Yes.
still I'm asking.
It's a very rare scenario. You would still be guided by the localization of the clip. If the sonologist, excuse me, if the sonologist notices post-neoadjuvant chemo, there is a residual tumor burden is still visible, and the marker clip is away, hydrogel or whatever marker is away from the lesion.
Right.
Then what they would do, they can sometimes put two marker. One wire is right at the remaining cancer, so as done, and they will then mention how far distance is the clip. And if they say that it is quite well away, and leave that. There are occasions I have come across in UK in my 20+ years experience that this sort of scenario that you are explaining is there, and we do not run after that clip. We just excise the residual cancer that is still seen on ultrasound, and the wire is placed. You just do wire-guided wide local excision of the remaining cancerous tissues, and sometimes we leave that clip. We don't go after that clip. Does it answer your query?
Yeah, thank you very much, Farid bhai. My question was that. And another thing I want to add for Lima Appa's question, that the question asked by Lima Appa, I asked the same question to my trainer during my fellowship in Singapore. So what she said, she took me to a surgery, and that was not dual tracer. Only no blue dye was used. Only the technetium 99 was injected the patient, and she asked me during the axillary part that you show me which node, if I ask you that you remove some sentinel lymph node without seeing anything, you tell me which node you will prefer. So I usually prefer the larger ones. And then we tried with the gamma camera and found that those were actually cold nodes, that those were not hot nodes. So always, if we like anatomically or presumptively, if we take out the nodes, that won't be essentially the sentinel lymph node.
Yeah,
so
definitely.
for that
That's
reason,
correct.
sentinel lymph node is very much important, and blue dye technique is not that difficult. The only thing is that difficult is that we don't have enough training facilities. So we should be trained from our country or somewhere else, and then we can teach others who know this technique. So this technique is not very difficult, but you cannot abandon the sentinel lymph node biopsy technique until and unless a newer like proven technique is there. Thank you very much.
No, I don't understand that why our surgeons are not practicing this technique right and left. I think this is not now so costly or not very.
Okay, I have Dr. Pradeep Kumar Mandal. Dr. Pradeep, would you mind to unmute and ask the question?
Thank you, sir. Sir, I want to know, during the simple mastectomy, how much thickness of subcutaneous fat and fatty layer should be preserved and should be help to prevent the necrosis also and clearance of the oncological clearance. Then
Clever question, Pradeep. Thank you. I got it. This is a common problem every surgeon faces in their mind when they do a mastectomy. And the reality is, the book will tell you that about 5 to 7% breast tissue is always left, no matter how meticulously you do a mastectomy. And those breast tissue could be found at the undersurface of the flaps, superior inferior flaps. Now, this is a purely technical question, basically. If you do a traction, ask your assistant with a traction with a clip or a catch paw away from the breast upwards, 90-degree angle up, and you push the breast tissues with fingers away, and you will find there is a tension line, there's a white line appears, and that is your level. So if there is a chubby patient, overweight patient, then you may be able to find that plane where you see a lot of subcutaneous fat, and then breast tissue in between interface, there is a white line. That is where your dissection is. So it is almost always you will find that white line at that plane. So traction, counter traction appropriately given, and you'd be able to see that line and carry on dissecting. Try not to expose the dermis, because that's when you get the risk of damaging the vascularity, and then skin necrosis can happen. And obviously, if there are stories like patients are heavy smokers, try to leave a little bit of more subcutaneous tissues than the normal, because they are the ones they would have wound failure, high risk group patients. So those who are heavy smokers, diabetic, uncontrolled diabetic patients, or are on a steroid, try to leave a little bit of more tissues. The standard, the principle never changes. Try to find that white line of plane between subcutaneous fat and the breast tissues, irrespective of the patient's height, weight, or the breast shape. Jakirullah, do you want to add anything else on this?
I completely agree with Farid. This is a very interesting question. The reason I'm saying that, this is also again going with the training. Why I'm saying training, I've seen some mastectomy done in some European countries. They're mostly plastic surgeons doing mastectomies with some training. Their mastectomy is, it's frightening, because they're more interested about the instead of oncological thing, more cosmetic area. So they make beautiful reconstructions, but the frightening way they do mastectomy, they leave half of the breast tissues. So in my opinion, with my experience, if you have got a good training, you always find out that plane. Irrespective of fat or non-fat person, yes, subcutaneous fat layer and the breast tissue slightly differ. The fat of breast and the subcutaneous fat is slightly different. One is slightly yellowish and the other is slightly whitish. However, at times it might be very difficult to find out. I completely agree. But about 3 to 4 centimeter, so 3 to 4 millimeter thickness, and when you actually feel that the flap is not going to die because of your dissection, that is the plane where the white line you will definitely see, what normally Farid said. Yes, but sometimes it might be difficult. So my advice would be keep at least 3 to 4 millimeter thickness. That flap will survive. But if you feel that you're leaving more than 5 millimeter or more thickness, then you are actually not doing the real proper oncological surgery. But it can be, you need to have a practice again and again. That's my opinion.
So
Can I ask another question?
We can finish it, because if this question goes on, already we are and we need to proceed. We have some discussion today. So very quick comment. Can you stop your screen there? John, any quick comment? John.
I can't hear. There is a lot of background noise.
John, can you hear me? Can you just unmute and make some quick comments from your end?
Yeah, Farid, I thought today's talk fantastic. You covered so many important points, and particularly from an oncologist perspective, you know, it's the key nuggets that really matter when we're in MDTs. And I think you really pulled out the things that, for me as an oncologist, are most relevant for the patient. Thank you.
Thanks very much, John.
So Farid, can you stop sharing your screen so I can?
Done. Thank you very much, Conway. And thank you all for listening.
Thank you. Now we are moving to our...
Kamal, can I just comment one thing before you start? Sorry about that, about Farid's talk. Come on.
Yeah, please.
Sorry. I mean, I think the most important slide Farid showed was the last slide. This is just to bring all oncologists and surgeons together. Because it's frustrating to hear that sometimes our oncologists are not actually respecting the surgical decision in Bangladesh. And that is really, really very shocking. The reason I'm saying that, last page, if you see the slides it showed, please don't tell any, oncologists should not be telling surgeons what to do. It should be a combined multidisciplinary approach. Otherwise, patients will get confused. And this is the last thing we need to do in Bangladesh. Patients are already confused. And we are trying to build an atmosphere where everybody is talking the same language and same thing. I'll ask and request everybody to read the last slide from Farid, and that will explain everything to you, what we need to do. Thank you very much, Farid. This is a fantastic presentation.
Thank you very much.
Thank you, Bhai. So I think what the message is, it is not I, it is we that we should be practicing. We should forget I in the field of oncology management. So very quickly about the last week, we had a wonderful session with Peter Smith and Dr. Rudangshu, and we had 99 participation, and we had a few quiz participation was 25, and the winner was Dr. Sharif. And what is important is that there was a heterogeneous performance in the quiz. Everybody was not doing the same, and the participation is gradually, it is showing a good trend of increasing, persistent increasing trend session by session. So that was the last week present evaluation. Now coming back to our today's case discussion, last year we didn't have a case discussion. So may I request somebody to quickly come as a volunteer so we can go for our case discussion. This will be a case on TNBC. Anybody? You know, if you are participating, you will get 10 bonus. And once you get 100 bonus, there is an award for you. And many of you have 30, 40 bonus already achieved. So anybody want to volunteer? Quick.
Sir, can I?
Who?
Can I?
Sir, Riyad, sir.
No, somebody
And
has.
another one, Nusrat is responding.
Who was another?
Who is responding now?
Sonia.
Sonia, okay.
So Sonia, we are here. There is a 43 years old lady presented with a lump in the right breast. Mother died from breast cancer 5 years back. Her ultrasonogram and mammogram both was done as Farid said. Now we are not going to do only ultrasonogram, and it showed the solid cystic mass lump around 5 centimeter, highly suspicious malignancy in 2 o'clock position with right axillary lymphadenopathy. Left breast was normal. What next you want to do, Sonia?
I will do core biopsy from the breast lump
Okay.
and and fine needle aspiration biopsy from the lymph node.
10 out of 10. The core biopsy was done, and it shows that invasive carcinoma of grade 3. Unfortunately, the lady became triple negative, and as your suggestion, we have done a FNS and it showed metastatic carcinoma. And then we have done the metastatic workup with CT abdomen, chest, and pelvis. There was the findings was consistent with the ultrasonogram finding. There was no sign of distant metastasis. Bone scan was done. There is no metastatic disease in the bone. So finally, we radiologically conclude that clinically it is a C2N1M0 TNBC. So do you want to do any further investigation, Dr. Sonia? Or you want to go to the treatment?
Metastatic workup already done. I will go for neoadjuvant chemotherapy.
Very good. So what will be the treatment modality then? Only neoadjuvant chemotherapy, then what else?
Neoadjuvant chemotherapy followed by surgery, followed by adjuvant management.
So very quick talk about TNBC is a heterogeneous disease. It was last week discussion. Dangerous thing is occurs more in the younger woman, and it has a propensity of visceral involvement, including CNS. Most BRCA mutant develop TNBC, and BRCA mutant 20% of 20% is TNBC, and only 5% is TNBC. And among these 20%, 16 is BRCA1, only 4 is BRCA2. And around 10% of all breast cancer is TNBC. So
I will do mutation BRCA mutation status and
great. So there is a big discussion we hear. TNBC rate is very high in Bangladesh. So I was looking at the paper.
If the facilities are available.
Yeah, and it was they have shown the two literature published here, where Mustafa et al. Have shown 9% and Rahman et al. In South Asian Journal, there's 20 to 26%. So even we have a perception that there is a very high prevalence of TNBC. Unfortunately, either it is wrong or it is not yet been documented. So it is very important that if we really think something, we should publish it to claim that there is high rate rather than making some comments that we usually do. So all TNBCs are not bad. There are some good TNBC, there are some bad TNBC. So there are some TNBC like medullary apocrine, adenoid cystic, metaplastic, low-grade, and secretory. These are, even TNBC is of good prognosis. So the MDT, as you said, decided like just you said, NSCT, surgery, adjuvant chemotherapy plus minus because it depends, and adjuvant radiotherapy. So my question is, Sonia, that why MDT and you, both of you are talking about neoadjuvant chemotherapy? Why not upfront surgery and then go for adjuvant chemotherapy? We know that it is okay, we can treat. So why? What is the logic in favor of NSCT?
Triple negative breast cancer is had a high propensity of distant metastasis, so that I recommend for neoadjuvant. So recommendation chemotherapy first.
Neoadjuvant distant metastasis can be taken care of by even adjuvant chemotherapy. But another point is that if you look at the most popular, that if the tumor
neoadjuvant chemotherapy, if we give neoadjuvant chemotherapy, pathological complete response will be good.
So if you look at the criteria, this patient is more than 2 centimeters and this node positive. Both the criteria is there. So it is an ideal patient of TNBC to give that neoadjuvant chemotherapy. It is NCCN and ESMO, both America and Europe, both is recommending the same thing. And you see what you say, that there's a significant difference of pathological complete response with neoadjuvant chemotherapy if you compare between TNBC and non-TNBC. And which drug will you choose, Sonia, for TNBC?
Dose dense AC followed by taxane plus minus immunotherapy.
Dose dense AC followed by paclitaxel. Very good, Sonia. You are really wonderful. Maybe you took a very good preparation and came, and I really appreciate it. So, what about platinum? You know, Farid always talk about why
Yeah,
not
sir. If we add platinum, the pathological complete response will be more good, and overall survival and event-free survival will be more.
So you see, there is a wonderful meta-analysis, and this meta-analysis was published in Annal of Oncology, and they have taken 9 RCT and 2,109 patients, and they have shown the pathological complete response is 52.1% compared to 37% when you are using platinum compared to the conventional chemotherapy. So they have concluded that platinum could be a reasonable choice for neoadjuvant chemotherapy in TNBC. So what about nab-paclitaxel? We know that paclitaxel is fine, but there is a nanoparticle paclitaxel which is quite popular. Do you have any idea? Would you like to use nab-paclitaxel as NACT in this case?
Yeah, we can use paclitaxel.
Why? Any logic? This is a session we are always talking with evidence. Do you have any idea?
Nab-paclitaxel is the albumin-bound nanoparticle, so hypersensitivity reaction or others may be minimized.
Thank you, Sonia. That is a wonderful answer. But we are talking about the effectiveness. There is a trial called ICNA trial. ICNA is the evaluating treatment with neoadjuvant Abraxane. But this trial failed to prove any superiority of nab-paclitaxel over normal paclitaxel in neoadjuvant setup in all group and even in triple negative group. But another German trial, that is Gipersecto, they have shown that
yes, sir. Nab-paclitaxel have role in metastatic setting.
It's in superior to conventional. There was 1,200 patients, and they have shown that nab-paclitaxel is showing more pathological complete response compared to conventional. There is a basic difference between these two trials. The drug that they have used in ICNA trial and the drug dose they have used in Gipersecto trial is totally different. So maybe the total cumulative dose of paclitaxel and nab-paclitaxel has created this difference. So we can say that Gipersecto trial is an evidence to justify the use of nab-paclitaxel in the neoadjuvant setup. So can you think anything better? We are thinking of platinum, from dose dense to platinum. Now, what about immunotherapy? Patient is rich. They want the best. They want to do a neoadjuvant treatment. And can you think of something?
Yeah, we should offer immunotherapy in early stage and metastatic setting.
We're talking about neoadjuvant. What drug you want to give?
Yeah, pembrolizumab.
Very good. You see, this gentleman, you know the man?
Yes, sir. Yes, sir. In last setting,
yes. So is the
in keynote 5222 trial.
Yes. Wonderful. So you know everything. Before this presentation, I didn't know it. So this was a trial, and they have shown that adding pembrolizumab to taxane is showing survival, more pathological response, and above platinum. Platinum was something around 50. Now it is 64.8. So in addition to pembrolizumab in TNBC is showing one of the best pathological complete response. So if you want, you can really discuss with the patient about adding pembrolizumab. So now let me change the case slightly. It is no more T2, it is T0, but still N1. Would you still go for neoadjuvant chemotherapy, Sonia, or you will go for surgery?
Yes, sir. According to NCCN, according to NCCN, N1, we should go for neoadjuvant chemotherapy.
Wonderful. I mean, I tried to create a trap, but you didn't land to the trap. Yes, even in T0, but N1, in TNBC, the recommendation is you should go for, it is a candidate for neoadjuvant chemotherapy. So it depends on the tumor biology, at a high Ki67 TNBC and HER negative. I mean, all these are the issues. Even with T is not the factor, even node positivity is a logical option for neoadjuvant chemotherapy. So now the patient was given neoadjuvant chemotherapy with carboplatin and paclitaxel, followed by EC4 cycle. Clinically, there was a partial response. MRI has done as Dr. Farid recommended. We have done MRI, and it had shown the 25 millimeter mass. There is partial response, and clinically now N0. Now, this patient, will you go for, breast conservation surgery or not? Because it is a TNBC, it is a positive family history, and there is partial response. Will you go for mastectomy or will you go for breast conservation surgery?
No, breast conservation surgery could be possible.
So we discussed in earlier that neither family history nor TNBC is the
contradiction breast conserving surgery.
Partial response if the surgeon feels the tumor size is good enough to give a good shape of the breast, that is the remaining tumor and the whole breast ratio and the location. If they think that the good cosmesis is possible, definitely we should go for breast conservation. So now breast conservation and Xray lymph node dissection was done. Residual tumor pathologically came out 20 millimeter, grade 3 ERPR negative, HER2 negative, Ki6 testing 25%, less than 1 millimeter posterior margin, N0, YP2 N0. Now, the patient was given whole breast radiotherapy with regional node radiation, 50 gray 25 fraction with boost 16 gray 8. Now, will you give this lady adjuvant treatment, Sonia?
Yes, sir. 6 to 8 cycle of oral capecitabine can be advised.
So, would you, at this moment, do you think that there is any justification of asking her to do a BRCA test here?
Yes, sir. If we want to advise immunotherapy or PARP inhibitor, BRCA mutation is needed. BRCA mutation testing is needed.
Very good. So you see, always you go for the evidence. You see, if you look at the early stage breast cancer, no chemotherapy and our adjuvant chemotherapy, there is a absolute disease-free survival benefit. So it is the justification of giving adjuvant chemotherapy. And if you look at the relationship with the PAT-CR and the survival on all the residual tumor volume and the survival, there is a wonderful relationship. So when there is some residual tumor, we need to take care of it because it affects the survival. Now we have done the BRCA test and the lady unfortunately is BRCA negative. Now what drug will you give, Sonia?
Capecitabine.
Thank you. So NCCN is
6 to 8 cycle.
6 to 8 cycle. Yeah, just memorized NCCN. I can see that 6 to 8 cycle of capecitabine. But mind it should be given after radiotherapy.
After radiotherapy, yes.
Along with radiotherapy. When we give hormone, it can be given with radiotherapy. But when we are giving any chemotherapy,
it should be after.
We don't give concurrent. It is always neoadjuvant or adjuvant with radiotherapy. So this was a NEGM paper. This paper was not based on TNBC. Actually, they have taken 910 patients, 84 centers, 62 in Japan and 22 in Korea. And they have taken a whole bunch of patients from stage 1 to 3B, and they have given acetaxane neoadjuvant, then surgery, and then they have seen the residual tumor given by capecitabine. And they have shown that all group, capecitabine group was showing some survival benefit, but the interesting finding was that in TNBC group, it was doing better. And that's why, with the base of this NEGM paper, we can recommend that not only NCCN is writing with this evidence. So we need to now start talking that not NCCN. We say that on this publication, on this outcome data, we are recommending that one capecitabine 1250 milligram mean square BID 2 weekly for 3 weeks, 2 weeks for 2 to 3 weeks, 6 to 8 cycle is the recommendation. So the patient was well on regular follow-up, and after 9 months of the patient capecitabine completed, patient complaints of abdominal pain, and ultrasonogram and MRI abdomen confirmed multiple SOL and both lobe of the liver, favoring liver metastasis. What will you do? Start gemcitabine carboplatin, start nab-paclitaxel atezolizumab, biopsy to confirm TNBC and start gemcitabine carboplatin, biopsy to confirm TNBC and start nab-paclitaxel atezolizumab, or biopsy to confirm TNBC send sample for PDL1 testing, and if positive, start nab-paclitaxel. So there is 5 options. Which one will you take, Sonia?
Biopsy to confirm TNBCs, number 5.
Very good. Because this is another publication of Impatient 130, that is also the main PI was Peter, and there they have shown that atezolizumab and nab-paclitaxel is doing wonderful result in triple negative metastatic setup, but the PDL1 positive group is doing better. So agreed that we will go for the last option. So I found this interesting thing published, that what are the metastatic TNBC. If it is PDL1, we can go for this. If it is BRCA mutant, we can go for platinum or PARP. But if it is PDL1 negative or BRCA wild, then we need to put a normal conventional chemotherapy or clinical trial. So the patient was on regular follow-up, and now the patient by this time received 2 lines of chemotherapy, and still the patient is having a disease progression. Can you think of anything else, Sonia? Okay, so this was the paper, the Orunanshu discussed.
Yes, the last session, Sir showed the sacituzumab.
This is a very small trial, but they have shown that in 3rd, 4th line, even after quite a more than up to 10 therapy, they have shown the 3 median previous therapy, it is showing a good response. So we can conclude that TNBC is a heterogeneous disease. In 2020, there are multiple options of treatment, but we need to do the proper selection of the patient and also the proper selection of the treatment. Thank you very much, Sonia. You have done a really wonderful job. Thank you. Congratulations.
Kamal bhai.
Thank you, sir.
Simply awesome. I have another thing to say. Sonia, can you show your face?
Yes.
We need to know how do you look like. Very well done. Very well done.
Okay.
Very serious student.
Sir, I was your first resident.
Yeah.
Kamal sir, I was your first resident at NIENT.
Hospital.
Yes, sir. Madam, I'm from NICRH, radiation oncology resident. You are a student.
Sonia, when I was almost
I
forgetting.
always see you running here and there, always.
The thing is, when I was
Kamal bhai,
yes.
Kamal bhai, শুধু একটা কথা একটু অ্যাড করতে চাই regarding adjuvant, মানে those patients not achieve complete pathological response after neoadjuvant chemotherapy in triple negative breast cancer. So in particular in these cases, we really sorting for some sorts of adjuvant treatment.
Yes.
So here come the question regarding the capecitabine.
Yes.
So আমি জাস্ট একটা কথাই বলতে চাই যে ক্যাপিসিটাবিন যেন মিসইউজ না করা হয়। এটা কিন্তু লাস্ট অ্যাসকোতে ডিটেইলস ডিসকাশন হয়েছে যে সব গ্রুপের জন্যই যদি রেসিডুয়াল রয়ে যায় তার জন্য সবার জন্যই কিন্তু ক্যাপিসিটাবিন কোনো বেনিফিট দেয় না। অনলি ফর নন বেজাল টাইপ ক্যাপিসিটাবিন ক্যান বি বেনিফিশিয়াল। সো এই জিনিসটা মাথায় রাখা উচিত যে ক্যাপিসিটাবিন সবার জন্যই না, যে টিএনবিসি আমরা নিওয়ারজেভেন দিছি আমাদের রেসিডুয়াল রয়ে গেছে সবার জন্যই কিন্তু ক্যাপিসিটাবিন না। ইট ইজ অনলি ফর দোজ আর নন বেজাল।
Thank you, Shuman, for the addition. And Sonia, thank you very much. So she was my first resident in NIN, what she said, because the Cancer Institute was so kind to send some resident, and she was the first resident, and I really enjoyed. And today I'm proud of you, Sonia. I'm really proud of you. So now it is
extraordinary performance. Very good, very good.
So you can put the link of the quiz in the chat box.
All right. Do you
Yes.
want to ask John anything about your lovely presentation? If there is anything you would like to add.
We should take his opinion.
It's fantastic. Congratulations on knowing all the answers, you know. That was really good.
So the link is given. So anybody who is interested can join to the quiz. 5 minutes there. Zakir bhai, during the quiz time, we will be expecting that in some coming days, we'll be here listening to you about how to keep the data. So start slowly, take the preparation. I think
I will. I'll start. Yes, definitely. I'll start now. Tell me at least a couple of weeks ahead, so
yeah,
it's easier for me to
you
make
have,
sure that I'm on call.
You have 2 to 3 weeks.
Okay, no problem. That's great.
So that today we crossed the limit of 1 hour 30 minutes. I mean, blame or credit goes to Farid because he has created so many questions. And I remember he was telling that after core biopsy, the change, breast cancer, this lesion change. I remember one live case. The lady was anxious after the core biopsy and came to me, sir, the tumor is increasing very rapidly. You see, it is hot, it is tender, it is becoming bigger. So I don't want to wait for the biopsy report. I want the treatment. And unfortunately, surgeon suggested you should get it done immediately, surgery. Don't wait for the report and the chemotherapy. Unfortunately, she was a triple negative. I lost the patient, but I remember I gave the patient antibiotic because it was really badly inflamed. And within 24 hours, she called me that it was responding. So it really sometimes become confusing. And Farid, thanks for bringing up so many, practical issues that we face as oncologists if we don't have a very good communication with you. So it is not only you to blame, me to blame, it is us to be blamed when we are not talking with each other. So what Zakir Bhai said, I think the bottom line is we need to talk with each other. We need to share our strength and weakness. And that is how combinedly we can really do good to the patient. That should not be any ego that I am doing or, I can do it. That should not be there. And patient deserves that.
Thank you. Thank you, Kamal Bhai. Very valuable point.
Farid Bhai, it should be a relay race, not a 100 meter for you. It's a relay race, always.
Yes, that was the last point on my slide. You must have seen that. Thank you. Thank you, Shaida.
Yeah, and I love the last comment that you put in the slide. I remember one of my respected, type of mentor, when I got admitted in oncology, he wrote me a letter that people said you need costly equipments to treat cancer patient, but I think you need a good heart to treat a cancer patient. So after so many years, it was in 2003, I read this letter. So after so many years, I see the same, more or less same message that you put. It's wonderful, Farid, it was amazing. And I'm so happy that you have covered so many nice things. What Zakir Bhai was saying, that you have really...
I completely agree, Kamal. One thing we have to always understand that this is only one country where, with sorrowness, I'm telling you, that the patients are not actually treating doctors properly, unfortunately. So we have to take some responsibility as well. Because all over the world, everybody is praising doctors now. And even in COVID situation, what things we're seeing in Bangladesh, they're blaming doctors. And I think we should take some responsibility as well, because we don't talk to each other. We doctors are fighting each other. That's why until and unless we talk exactly the same language, the patient will get confused. So this is a fantastic platform you have created, Kamal. I appreciate you. I definitely, unbelievable platform you have created. So if you carry on working on that platform, I'm sure one day the system will be much better and patient will start respecting each and every doctor. I'm pretty sure.
Thank you, Zakir Bhai. Actually, credit goes to the man, the old man, Professor Karim, who started it. And now Professor Ha, you see, he joins before us and he stays here full time. That is the patronization. That is the leadership that we are getting. We are so fortunate to have somebody like him who is really leading us. And especially we are amazed by the participation of the young oncologists. You see, every week they are coming 50 to 60 people. So that is the strength of our program. And the faculties like Shumon, Lima, Dr. Asma, they are making the best contribution. So thank you very much. So now we are again going to the presentation. So during they make the result, we are sorry. So we want to go to the rapid fire session. Anybody volunteer for the rapid fire session?
May I?
Who is it?
Me, sir.
Riyadh is.
Yeah. No, this is a surgeon presentation, and today it should be from a surgeon side. Kamal bhai.
Why not?
Yeah. Not always radiation oncologist.
But not necessarily.
Okay.
Anybody who is interested.
Okay, I'm there, Dr. Kollol. Okay.
Yeah, Dr. Kollol.
Kollol is not qualified.
No. Kollol should.
Okay.
So junior surgeon, any junior surgeon is there?
Any resident?
Be brave. Speak up.
Anybody? So then take somebody from oncology. So we need to move fast because already we are much late. So somebody volunteer other than Riyadh. If nobody, then Riyadh is fine. Riyadh is
Tamim raised hand.
very fast.
Kamal bhai, Tamim.
Shamim.
Shamim.
Who is Shamim?
Tamim.
Tamim is there. Dr. Tamim.
Let's start with Riyadh then.
Okay, Riyadh. Are you there, Riyadh?
Yes, sir.
Okay. What is the selection criteria of neoadjuvant chemotherapy in TNBC? It's a very peanut question for you.
Tumor more than 2 centimeter and more than or equals to N1 disease.
Very good. What is the percentage of TNBC shows BRCA mutation?
16%.
It's 20%.
20%.
BRCA1 is 16, BRCA2 is around 20%. Okay. So are all TNBC carry equally bad prognosis?
No, sir. No.
What are the good prognosis, bad prognostic TNBC type?
Bad prognostic, other than medullary apocrine, adenoid cystic, all are bad prognostic.
So these are good prognostic. Medullary.
Other than
these are, yeah, good. Smart. Smart, very smart. Okay. So what percentage of PCR is achieved by adding pembrolizumab with
64.8%.
Sorry?
64.8%.
Yes. Keynote 522 have shown that 64.8%. Today I think I should have taken a better preparation. Both Sonia and Riyadh is out, doing so wonderful. I'm feeling really, I should work hard. Okay, in BRCA negative patient, which drug is the choice for residual disease?
Carboplatin.
In TNBC.
Capecitabine, sorry sir, capecitabine or irinotecan, yeah.
If it is BRCA positive, then you can think
then
of
carboplatin, yes sir.
Okay, so what will be the sequence of capecitabine with radiotherapy? We deal with along with radiotherapy or
after radiotherapy? After
yes,
radiotherapy.
it should be after radiotherapy. Maybe it sounds silly, but I brought it intentionally because these are the small areas where we are sometimes making confused, and that's why NCCN has categorically written that it should be given after radiotherapy, not to be confused. So, if family history of TNBC contraindication for BCT?
No.
So, in BRCA positive patient, which drug of choice for the residual disease?
Either carboplatin or PARP inhibitor.
Okay. What is the role of PD-L1 in the management of metastatic TNBC?
Role
of PD-L1 testing in metastatic TNBC?
Yes, sir. There is role of PD-L1 testing because if it is PD-L1 positive, we can start with atezolizumab.
If it is not PD-L1 positive, will you not give atezolizumab? You look, see, inpatient trials said that both PD-L1 positive is doing better, but if it is not even positive, they are also not doing good. So it can be given, but it is a prognostic value that PD-L1 positive group will do better. Their outcome is comparatively better than the negative group. Which group patient gets most survival benefit from RT among TNBC patient? Mastectomy or breast conservation radiotherapy?
Breast conservation.
Yes. So thank you, Adnan. Riyadh, I think it was too easy for you, but I couldn't find more tough question for you. So it means that you have become so smart, I cannot find enough tough question for you. So I think.
But Kamal sir, today it was a surgery presentation. So the rapid fire should be on surgery.
Yeah, I know, but I'm not a surgeon. Maybe next time I will give you the responsibility.
Kamal
I can
bhai,
see there are a lot of.
Yeah, you carry on.
So
Yes,
please,
I can see there are a lot of good attendance and some very senior professors attending, and even from dignitaries from abroad. So it's really a good gathering and an excellent presentation. Especially, you done a great job, Kamal bhai, and the answers from the trainees were amazing, simply amazing. I've learned a lot today. Thank you very much.
Thank you for it. So I think somebody is developing a habit of getting a prize, and quiz winner is
Sharif.
No. Is Dr. Riyadh.
Okay.
Congratulations, Riyadh.
হ্যাঁ আপনার প্রশ্ন চেঞ্জ করতে
Thank
হবে
you, sir. Thank you, sir.
You have to change.
So Riyadh, congratulations.
Thank you very much, sir.
Was 90 out of 100.
Thank you, sir. Thank you very much.
It was 90 out of 100. And what I understand that we had an extensive discussion of TNBC on last session and today. And that reflects that our participants were doing fantastic when we were discussing the cases and the rapid fire session. So now I will ask anybody from Sanofi. Lucky, are you there? Or Nahid? Anybody there from Sanofi? I think there is nobody. So thanks to Sanofi for being the partner. And as Farid says, that I have seen there is quite a few senior professors attended. Thanks to you, sir, for supporting us with your presence. And thanks to Aisha and Veronica for enriching us with your participation. Really, it was international where with the faculties, now it is international with the participants. We are so happy and we are so proud that we could bring everybody together. Now, next week, we will be having a session on nodal irradiation in breast cancer. And Karthik will be the speaker like last time. We will try to cover the nodal irradiation because it is very important. There's a big change in nodal irradiation story in breast cancer in very recent time. And still then, I would like to say that whether John, would you like to make some concluding comment? Because we are almost at the end. Then we can finish. John.
Yeah, no, thank you for inviting me today and really for a really interesting talk from Farid first. And then I thought the case study in terms of triple negative breast cancer, it's probably one of the most evolved specialty areas in breast cancer now with the advent of immunotherapy. And I think today's case study covered all the most salient points from the early to the metastatic setting. So well done as well to those who answered the questions. You did better than me, probably.
Thank you, John. So with this, and thanks to, again, I'm really thankful to all the seniors. I am not mentioning the name because maybe I will miss some. I'm really amazed to see the names. I cannot believe my own eyes that who have participated. All the senior professors of surgeries have participated. I see Professor Mahabul Alam, Professor Muhammad Ayub Ali, Professor Ataur Rahman, Professor Sitabur Rahman, all seniors. Your support is the secret of our going forward. Nahid, are you there? Nahid? Hello, Nahid. So, sir, hi, sir, are you there, sir?
Yes, I'm here.
Sir, if you conclude, if you say, then if you allow, we can conclude this. Already we are over the time, already half an hour late, sir.
Possibly we shall have to take more time next time. 2 hours time.
1.5 hours possible is very small time. Well, we had a very lively discussion today and very many things were discussed. Everybody was happy. We had fun participants also. I will be able to, I shall be like to have their comment about our program, if possible. Possibly from Veronica didn't take part in discussion. Didn't put any question. However, next time she will. Next week we are going to have radiotherapy. For participants, for failures, tell for faculty will be the same or shall we change someone? I think John is become very.
Thank you, sir. So, as sir said, that we will be proceeding forward, and next, just for your information, next Friday we are going to have a session for our radiotherapy technologists. We will send a mail to you so that you can ask your technologists to get registered and participate. It will be a session on how to do safe handling of patient during COVID for the radiotherapy technologists, in our country, because they are the people who are handling patient, and we think we need to educate them also. So that's why our oncology club has taken initiative. Professor Dr. J.P. Agarwal from Tata Memorial Hospital and Mr. Gurvinder Singh of Rajiv Gandhi Cancer Center will be the faculty. And please try to ask your RTT to join the session. So until next week, you will be enjoying a session on nodal irradiation. Till then, stay safe and have a good life. Let us wait to enjoy the next session. And thanks again to our overseas and local faculties and participants. And last but not the least, again, thanks to Farid and our volunteers for your wonderful participation and presentation. Thank you. Thank you.